as an organization, 75-year-old organization that deals with all aspects of public health, clinical health, policy advocacy, working with various partners. We felt that there have been many questions, many doubts, um, more so because of also the big focus on cervical cancer these days. And we thought the best way to then move forward is to bring experts together of various expertise streams. And so today we are really delighted and honored to have three experts who will take us through the primary prevention aspects of cervical cancer.
Cervical cancer is a risk to women of all ages. And worldwide, there are about 5 lakh cases recorded every year. And nearly 2,88,000 women die every year worldwide. And it's the second most common cancer site in women worldwide. Now, what are the risk factors for cervical cancer? Now, the main risk factor is infection with HPV virus, which comes through sexual activity, and infection with HPV and risk for cervical cancer include having multiple sexual partners, having sex with a promiscuous partner, history of sexually transmitted disease, sexual intercourse at a very young age, before 18, patient or the partner has or had a genital wart or a virus infection, not using condoms with new partners, sexual partners whose previous partner had a cervical cancer or abnormal cervical cells, and sexual partner who has had cancer of the penis. So these are all the risk factors. And about 11.4 is the mortality per 1 lakh population. So we are 4th in mortality and 5th in incidence in Asia. Now, just for the information of people who are also some of our non-medical staff who have joined, this is how a normal cervix looks. This is the mouth of the uterus, which is otherwise called the mouth of the uterus or the cervix. This is the external os. And this is a healthy cervix, which normally looks pink and smooth. And this is a normal cervix. And this is a cauliflower-like growth. This is what is called the exophytic growth. This is cervical cancer here. Now, how does this HPV vaccine, HPV infection spread? It is spread by direct physical contact, any genital contact, not just sexual intercourse, and hand to genital contact also can spread this infection. Anyone who is sexually active is at risk. And the risk of acquiring HPV increases with the number of sexual partners. So HPV infections cannot be treated. We don't know a woman has got HPV infection, and hence we cannot treat it as well because she won't have any symptoms, she won't have any signs. But the changes which this HPV infection can cause in the cervix, the precancerous lesions, they can be treated before it becomes cancer. 40 types are transmitted by sexual intercourse or genital skin-to-skin contact. So 99% of all the cervical cancers are caused by HPV infection. And out of that, the HPV 16 and 18 are the ones which are responsible for 70% of the cervical cancers. So why younger people? Why children between 9 and 14? There's always a question. They are not sexually active. Why you want to give them at 9 to 14? Because they have a better immune response. Because the better efficacy in the naive group, they are not at all exposed to HPV vaccine. So the immune response is better. And it's also a better compliance when you link it with the childhood immunization. So in 2020, the WHO set the 90-70-90 target, aiming to eliminate cervical cancer by 2030. So according to WHO, we vaccinate at least 90% of the girls, screen 70% of the women, and treat 90% with cervical disease. So yes, we can prevent cervical cancer.
The WHO position paper on HPV vaccine, which was published in August 22, has talked about implementation of vaccination against HPV, which could prevent almost 60 million cervical cancer cases and 45 million deaths over the next 100 years. And therefore, it should be included in all the national immunization programs, which should reach 90% of girls by the age of 15 years by the year 2030. Pregnancy testing is not needed before vaccination, though HPV vaccination is not recommended until after the pregnancy, and no intervention is needed if vaccinated while pregnant. HPV and screening for cervical cancer should not be age restricted. We are seeing it even in postmenopausal women, where the woman probably has not had a pap smear ever in her life, or maybe she's not received the HPV vaccine because she missed it. And therefore, the current generation of menopausal women or older age women need to be evaluated before they go in for any kind of a surgical intention for hysterectomy, especially hysterectomy. Because everyone thinks the job is done, her problem has got solved, and nobody realizes, and she may come back later with a recurrence of malignancy at the vault. Now, I've seen patients where they've undergone hysterectomy and they've come with a biopsy report. The hysterectomy is done somewhere else, and they come back with a biopsy report saying that, it is a cancer in situ. Where the biopsy sample of the uterus, which has been and has undergone histopathology after surgery, and that shows that there is a malignancy in the cervix. Now, this is something we should not lose this opportunity, and it should become probably mandatory that we should do a pap smear or an HPV test or whatever we would like to do to make sure that we do not lose this opportunity and let a woman at that age have a malignancy which may be going further from her vagina. And this is something where all of us should get together, and I think Family Planning Association is doing a great job bringing people together, leading international agencies, WHO, public cancer advocates. It's important for us all to get together to create this awareness and education. We have a digital app called Too Shy to Ask, which is focusing on educating and awareness of the adolescents on different issues. And one of the issues we have is on STI awareness and what every teen needs to know and can be prevent cervical cancer.
So it's important for us to realize that spontaneous clearance occurs in 90% of the cases. And therefore, it's very important for us to realize that we cannot use HPV test at any time of the lifetime for a screening purpose. It has to be used much later in a woman's life if we need to really catch hold of the persistent viral infections. This is something that we need to understand before we actually write down about our HPV tests. The second advice I would say is we should advise 2 to 3 days of abstinence at a minimum before we actually ask for an HPV test. We must also understand that this virus causes a very, very local inflammation in the cervix. It does not cause any viremia. How does this immunity actually work? The primary immunity is from the neutralizing antibodies. These are the main effectors of protection, and they prevent the initial entry of the virus into the basal epithelial cells. The vaccine that we gives rise to both neutralizing and non-neutralizing antibodies. And when we actually test for vaccines in research studies, we generally test for a combination of both, but we also test a proportion of the samples for the neutralizing activity that happens. The one-dose human papilloma vaccine seems to make a lot of sense for a country like India with such a huge population. That will make the dream of our Prime Minister, who wants every child to be protected, actually work. If we focus our attention on giving everybody more than one dose, then we probably get a little more quality at the cost of the quantity that we could cover.
Yeah, that was really, really very interesting, and it gives a complete finishing touch to today's discussions. So, friends, we have heard from the three experts. There have been iterations of important points. So, I would request you all to type in the Q&A, but let us start with the questions that I have already been able to collate. And I will open the question, and any of you could answer from Ashok Samantre, our branch manager from Bhubaneswar. He has a question that whether the government at state levels have started the vaccination, and can the school students be then the target group, because we get a majority of school people. So, what would be, and has it started, any information on that uh, from any of you, please?
Sikkim government has already given all the girls in Sikkim between 9 and 14, they've done it as a state health program. But as I know, I'm not aware of any other states. But recently, finance minister and the prime minister both have said, so it should be coming shortly as a government program.
The National
Yes. Yes.
Technical Advisory Group on Immunizations for India, the NTAGI, that decides on the free universal immunization program, is actively considering it, but no recommendation has come as yet.
Yeah, okay. So we know that because of the very famous budget speech by our Honorable Finance Minister, the budgets probably during this finance year will be allocated. But we all know India is such a big country to scale. And how do we roll out the commodities, the numbers? How do we follow up? How do we ensure a proper awareness? And I really think that to scale, it may not be possible immediately. There will have to be something which will roll out in time. It cannot be done like now. So, Ashok, to answer your question, that it is at the moment strategically. I think there are discussions happening. Funds have been allocated, but I think it will. We have to see at a scale, at the district level, state level, how it is rolled out. Um,
Both Gardasil and Cervarix have been available in the market ever since 2007 or 9, I'm not sure, sometime, almost more than 15 years now. And the people are giving in the private sector, they are giving these vaccinations. Even Gardasil 9 is available, and that also is being given in the private sector. And now FPI, we ourselves are giving in various schools. We have some of our branches have got funds, they have mobilized funds, and they are giving in schools vaccination. And to mention, Dharwad has already given about 350 doses. Bangalore branch has given 400 doses. So in our own way, small way, we are doing it. But government should do it as a national program, which should happen shortly.
Moving to the next one from Seema Sahai. What tests could be done or should be done before opting for vaccination in context of sexual assault victims? Are there any tests recommended?
I can take that if no one else will.
Yes.
Yeah. So when it comes to rape, our immediate concerns are HIV, hepatitis B, not really C. It's the care of the woman, any other sexually transmitted infection. Is she likely to be pregnant? And if her mental health and all those things are of primary importance rather than an HPV vaccination. And therefore, at this point of time, there are no standard guidelines that talk about vaccination in such cases. Having said this, we also must realize that if this happens to an adult woman, the single dose vaccination or the 3 doses are not probably something that would be very useful to her at that point of time. All this said and done, the primary caregivers would have to take the call. It's not part of any standard post-assault management. Who have sex with men are really at very high risk of anorectal cancers and also oral cancers. So when we test for HPV carriage, again, we have to test for rectal HPV and oral HPV. But So for that, you can use the same swab that you use in the cervix. But when we do a pap smear in the rectal region, the science of cytology of the rectum had not been advanced until more recent times. But I don't know many pathologists who are probably of great expertise in rectal pap smears. We are currently, we have just about started doing a study for samples collected from men having sex with men from both the oral and the rectal region. If you wait a few months, we'll have some data that would be published and may help inform screening practices. For MSM, who are routinely under care in the Western countries, they do undergo some level of testing and pap smears as well.
Extremely important that we look at the male perspective, and we have Praveen Sonamne from our Pune branch who is asking very pertinent questions, and I think quickly we address this and hopefully we will close about 40 minutes late into the program. That he says that what are the tests for the of HPV for men? As there is a mention that people who have multiple partners, but then will it be appropriate to consider such testing for high risk communities like men who have sex with men and transgender people? And also his question, third question is that we have ruled out HPV DNA self-testing with the help of pharma and one NGO associated with it. So there is a spatula with brush for insertion in the vagina. But is there any such tool for anorectal tests? So these are his questions. And if we could address these questions.
I can take that.
Yeah. Yes, please go ahead.
So men who have sex with men are really at very high risk of anorectal cancers and also oral cancers. So when we test for HPV carriage, again, we have to test for rectal HPV and oral HPV. But so for that, you can use the same swab that you use in the cervix. But when we do a pap smear in the rectal region, the science of cytology of the rectum had not been advanced until more recent times. But I don't know many pathologists who are probably of great expertise in rectal pap smears. We are currently, we have just about started doing a study for samples collected from men having sex with men from both the oral and the rectal region. If you wait a few months, we'll have some data that would be published and may help inform screening practices. For MSM, who are routinely under care in the Western countries, they do undergo some level of testing and pap smears as well.
Okay. So I think that ends our question answer, and I know that there are a lot of questions. There are some hands raised, but I'm sorry, we will not be able to open up for the people who have raised their hands unless they have typed a question in the question or a Q&A or chat box. Taking forward this, we will have another follow-up webinar on Spotlight on cervical cancer. Just summing up, I don't have words to sum up. I mean, these have been three great presentation, wonderful participative audience, all of you still at it 2 hours into a webinar unheard of. Just to say that we are a developing country. We have huge populations. Resources are thin, and even when the government says that they will allocate, but you can remember that Pradhan Mantri Modi ji has said that I would like to give a budget when budgets comes in. We need to understand that we will have to prioritize and look at the most at risk person and who is that person in the public health system. And we know that our women and girls do not have access to health equitably. Therefore, cervical cancer does remain a disease of inequality and ignorance. If you have the resources, you are not aware, you don't have resources and you don't have opportunities, and therefore it's extremely important from awareness to vaccination to screening it's all a continuum. We cannot say that one is more important than the other. But as a country, I think we are on the right track, and there is a lot to do. And when anything new comes, these are very good questions. And maybe if we had the same webinar in 6 months' time, probably we'll have some more answers and a better understanding. So thank you, all of you, Dr. Sheila, Dr. Durusha, Ratnamala Madam, for a brilliant panel today. And participants, you have been amazing. I mean, I have never seen such participation. Thank you so much for being with us. Watch out this space. We will come back in 2 weeks or 3 weeks' time for the next episode of the Spotlight on Cervical Cancer. So, with that, I think we close this session. Bye bye and have a good evening, everyone.